Hotbed Talk.
I'm James Hernan, a surgeon from Norwich. I have the great pleasure to co-host the last session with Professor Carley from Canada. And our first speaker is Gerrit Slooter, a surgical oncologist from the Maxima Medical Center in the Netherlands.
Thank you very much, Gerrit. Professor Duminda Wijeysundera is a professor of anesthesiology at Toronto.
Thank you both for excellent presentations. So we'll go to the first question. Doesn't delaying surgery for prehab depend on the type of cancer?
I so agree with that statement. I showed a slide on tumor progression over years, and that might be the case for colorectal cancer, but it's definitely not for every type of cancer. But colorectal is a high number, high incidence of tumors. We created a protocol for lung cancer, and we actually wouldn't accept any more delay for the treatment of lung cancer. So we have to involve patients in a prehabilitation program actually before the diagnosis is complete. So we will not induce a delay there. So it's definitely for a different type of tumor, there are different pathways and different growth patterns. Good question.
And so do you think lung cancer is just a special group and all the other solid organ tumours such as, say, gynae, renal, all fall in that colorectal group? Or
I think that's their biological behavior is really truly important for that. And for instance, kidney tumors, they have also have a slow growth pattern. So you don't want to get patients into a worse staging before you operate. And some progression will always be there, but there might be microscopic difference in a few weeks. But that's probably my answer.
Okay. Do you have any thoughts?
I think this is an area of expertise more for you. So not on that question. No.
Okay.
Well, I think we probably change and ask Professor Wijeysundera. You use complication as the outcome for your talk.
Yeah.
Clavien-Dindo, do you think is a good outcome? Do we need a better measure of morbidity?
So I think complications are very challenging. So they're clinically important events, but I think anybody who's done work in this area recognizes how challenging it is to actually measure complications. So I think Clavien-Dindo is certainly better than an ad hoc measure of complications because it at least gets a sense of not just the presence of a complication, but the burden of care that's imposed on it, associated with it, as well as effects on patients' prognosis. Do we need better measures of morbidity? The answer is yes. So I think it's a challenge. We thought that it was the best in terms of balancing, capturing clinically important complications and making the study practical to implement. But I'm certainly interested in looking at better measures of morbidity that you can apply in clinical research. I think it's a huge challenge in this area.
Why wouldn't you stay the same, probably? Did you look at the ability of the oxygen pulse limitation, which is a highly sensitive predictor of ischemia on CPET, and prediction of means on meds?
So we did not look at that. So what we had two components of data collection for CPET in the MET study. So we had stuff that was recorded directly on our case record form electronically, but we actually have downloaded pretty much all the raw physiological data from the individual CPETs, and actually that's led to a sub-study that's led by Mike Rocott and Denny Levitt here in the UK. So I think that is an opportunity to be able to get at some of those finer physiological questions about different measures of CPET aside from the classic metrics that people often use, so we can get a better sense of that. The other aspect is whether we can get a better sense of whether there's a difference in prognostic performance when you get centralized adjudication by a bunch of experts versus adjudication by trained individuals at local centers. We use trained experts at local centers because it was a pragmatic approach and it probably reflected how CPET would be applied in actual clinical practice, but that would help get at that. Would it be able to better predict ischemia? I don't know. I think one of the biggest challenges is actually our lack of clear understanding of what the underlying pathophysiology of myocardial injury and infarction after surgery. And it could be very well that preoperative ischemia may not, in the current epidemiology of myocardial injury after surgery, be the greatest predictor of postoperative infarction and ischemia? I don't know the answer to that, but I would suspect that the things that predict postoperative myocardial injury and infarction in contemporary surgery are probably things that are less related to exercise capacity. That's my hunch, but I'd be very interested in seeing what the relationship of O2 pulse and other physiological measures would be with that. I think that's an opportunity for an important sub-study and something we're working on.
So your study showed that most of the complications were non-cardiac.
Yeah.
So what's the mechanistic cause of those complications being related to poor exercise?
So I think so. Some are, I think, physiologic. So if you look at respiratory failure, I think we know that ventilation requires a whole component of our cardiac output. So if you have the inability to increase your cardiac output in response to stress, it's not surprising. Those are individuals who are probably going to fail. I think what's a bit more surprising is the relationship of infectious risk and complications and poor exercise capacity. But what's interesting is if you look at some other contemporary studies, it points to that relationship. So I'll look at the example of the OPTIMIZE-1 and OPTIMIZE-2 trials. So OPTIMIZE-1 showed, an almost statistically significant reduction in complications with cardiac output optimization. But if you looked at the events that were most sensitive to cardiac output optimization, they were actually infections. So again, suggesting there's a relationship between inability to increase cardiac output or the ability to boost it and infectious risk. The other thing that probably gets at it in a tangential manner is, frankly, the RELIEF trial. So, this was a trial of fluid restriction versus liberal fluid therapy. And, it was surprising that restrictive fluid therapy didn't improve outcomes. Some of the adverse events were not surprising. There was more acute kidney injury. But what's interesting is there was more surgical site infections in patients who were restricted. Now, is that a proxy measure for restricted cardiac output? I don't know. But I think it suggests that these relationships may be more complex and that actually maintenance or the ability to boost cardiac output may be an important contributor of actually mitigating risks of infections and surgical site infections.
Okay, so if we go to the next question, can we change the mindset about prehab? It does not delay the surgery, it's just the start of the cancer treatment.
Well, that's a question I can give back to the audience. Because I think these people here will believe that prehabilitation is a start of treatment. But unfortunately, we will have to convince others by hard evidence that patients do recover better, will have less complications, will be discharged earlier, and will probably live longer, because then you can truly state that it's the beginning of a pathway. And I think it's also the convention with which you tell a patient that he or she should work on his condition, that will help acceptance for that. If you look at results of CPETs and so on, we're describing patients as deviant from mean or deviant from average. And I think the average patient isn't that fit. There's a lot of sedentary people of older age. They sit on the couch, eat potato chips, have terrible habits, don't do any sports, spend their life in front of a TV screen. And average is not good enough. That's what I would state.
And I suppose we found in the UK, in terms of trying to convince our patients to do it, that's a big issue, trying to convince patients that waiting 3-4 weeks doesn't make a difference. And I suppose also the key decision makers in the NHS are still very much linked into the targets you suggest, the 62-day target and the 31-day target from decision to treat. What specific things do you think you can do to try and influence those individuals? You've done it to the audience, but how do you convince patients and decision makers?
Well, I was so enormously glad with the article of Ismail that I could actually use to give my talk with, because he found all the evidence. But the thing is, that's a project our PhDs are going to do, is that we're going to list a lot of countries and see what their guidelines are and what they're based on. And they're probably not based on anything, rather than you want to make sure you get away from exceptions. You don't want to let it overflow freehand, so that waiting times will be 12 weeks. By the way, 12 weeks was acceptable in academical situation 15 years ago. Nobody complained about delaying of surgery for 3 months.
Okay.
Yeah, I think there's an interesting question here. Is delay to curative surgery a reason patients do not accept prehab? Should we sell it like neoadjuvant therapy? It's actually quite an interesting potential comparison. We probably undervalue the fact that surgery has probably the same curative effect as neoadjuvant therapy. What will you comment on this?
I just don't understand the question, but that's my English as a non-native tongue, I guess. Is delay to curative surgery a reason patients do not accept prehab? Should we sell it like neoadjuvant treatment? You can sell second-hand car to a patient if you want, so you could call it any name, I think. But it's just explaining the benefits compared to the potential risk, which we think there is none.
Yeah.
Okay.
So I have a question for Duminda. What you show us very much that below 411, there is a signal there, right? So that would be possible that if we take a cut, let's say 400 meter, 6-minute walking test, around that, 350, 400, is that cardiology been using, 300, 350, let's say 400. Then we know that, and then we do the CPET at this point. It will be a screening test, and then we just go through the CPET. Well, what's your opinion about that?
So I think, there's been some work done on that actually from that same study that I mentioned that compared via sort of CPET versus 6-minute walk test here from the UK about can you use 6-minute walk test as a screening test for CPET. And what you get is you get a certain proportion of patients with very low 6-minute walk test values where frankly, 100% of them would have poor anaerobic thresholds if you tested them. And there's a proportion there, essentially, if you tested them, their 6-minute walk test tells you they will universally do well. The problem, much like, I guess, pulse pressure variation, is that you've got this huge gray zone where you have that interdeterminate zone. Now, frankly, that's probably where CPET would be most informative if your goal is to decide, does this person need, let's say, prehab or not? Are they sufficiently unfit that they need that? So I think it's actually identifying people in that gray zone where the test would provide additional value. Now, CPET provides a whole bunch of extra information beyond their VO2 peak and anaerobic thresholds. I'll acknowledge that. So I think that might be an approach. One of the things that there's a grad student who's working on that is exactly to figure out, can we use an algorithm where we could figure out that gray zone where we can refine the group of patients where CPET would provide the best diagnostic yield in risk stratifying patients. So I think it's probably going to be not so much patients below a certain threshold. It's going to be people within a window where we're not sure what their level of fitness would actually be. So
in a way, you're using the CPET to start the prehab. Not only diagnostic.
If that is the goal, to figure out are they really unfit or not. If that is the decision point that you're trying to inform. Okay,
so I think the oncology opinion came up the last time. Absolutely, it didn't get asked, yes. But the oncologist view, how engaged are they with the prehab, and what is their opinion, or do they view it as part of the surgical pathway? So are the oncologists important in all this, or they don't mind, they think it's all down to anaesthetists and surgeons?
There's so much difference among different disciplines. For instance, taking care of perioperative medicine is something big in the UK, and it's run by anesthesiologists. And in Holland, there's barely any anesthesiologist that is picking up the lead in perioperative medicine. It is the surgeons and the urologists that do want to do prehabilitation because they see the benefit of the patient. But we still need the evidence. And it's so weird. We have oncological patients in which training and exercise has been proven. There is evidence for training in oncological patients, and still these programs don't run. And I think there's a continuity between in prehabilitation and rehabilitation and taking care of oncological patients all along the pathway, even if they get adjuvant treatment. So there should be awareness from internal medicine and oncology to involve mental, physical, and metabolic fitness in actually every patient. It should be high on the agenda for every patient.
I think there's a study, Challenge, which has run out of Canada, looking at patients having adjuvant chemotherapy, which has been tried to be opened in the UK. There's been a real big struggle to get that group of patients in. I'm not sure why, whether it's funding issues, but so there is a study running looking at adjuvant chemotherapy, but hard to recruit to, certainly in the UK. Thank you very much for your talks and answering the questions.
Lee Wijeysundera here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.